Welcome to our lecture on right heart catheterization. This is John Boland. In this lecture, we'll have a look at the components of the Swan-Ganz catheter and how it's used, how it's prepared and inserted into the patient, and how it measures cardiac output by the thermal dilution technique. We'll also have a look at how it measures right heart catheter hemodynamics, including the pulmonary artery wedge pressure. This is that nice drawing of the heart you've seen before. I've chosen it again because it illustrates very nicely the anatomy we'll be discussing in this presentation. The catheter is inserted via the vena cava, either the superior or the inferior vena cava. It crosses the tricuspid valve into the right ventricle, and then it's twisted so that it crosses into the right ventricular outflow tract across the pulmonary valve and into the pulmonary artery along one of its more distal branches. And you all know those anatomical landmarks. This slide shows the blood flow through the heart, and you all know how blood flows into the vena cava and follows that very same course I've just illustrated. I'm showing this because the Swan-Ganz has an inflatable tip that, when inflated, gets propelled like a sail with the flow of blood in the direction of flow of blood, facilitates manipulation and delivery to the selected site. There are two catheters used to perform a right heart catheter: a cornered catheter without an inflatable balloon tip, and a Swan-Ganz catheter with an inflatable distal latex tip. The cornered catheter is stiffer, so it should only be used by experienced operators, but it can be useful in selected circumstances, such as in cases of latex allergies. The Swan-Ganz catheter is called a flow-directed pulmonary artery catheter for obvious reasons, and it permits the clinician to measure both blood pressure and take blood samples from the vena cava, the right ventricle, from the vena cava, the right atrium, the right ventricle, and the pulmonary artery. That's what the Swan-Ganz catheter looks like. It's yellow in this case, which they're color-coded for their purpose. This one, you can see, has a sealed syringe that inflates that little tip. It's not inflated. And you have little ports where you can inject saline or take blood out, the samples, and connect to a cardiac output recording system. It's 110 centimeters long. The balloon is 1.5 cc's in diameter, and the 4 centimeters proximal to this is a thermistor that is used to measure temperature. The connector for the pressure transducer. There are connectors for both the pressure transducer and for thermal dilution, as I've just mentioned. Preparation of the Swan-Ganz is critical. All ports should be flushed. Make sure there is no air. Balloons should be inflated underwater to test for leaks. Some attach syringes to the proximal and distal ports to prevent blood splatter, but I have never seen our operators do that. You can imagine it's critical not to contaminate the catheter with air, any invasive catheter with air. Indications: why do we do a right heart catheter? It's for diagnosis and investigation of shocked heart states, pulmonary edema, pulmonary hypertension, valvular heart disease, intracardiac shunts, cardiac tamponade, and for assessing the hemodynamic responses to different therapies, and for post and pre-cardiac transplant, particularly in our hospital. And there's a host of other reasons that we want to do. Contraindications: I think these should be intuitively obvious. Tricuspidal pulmonary valve mechanical prostheses. Don't take kindly to catheters that can get lodged because the valves are moving, and if the catheter gets jammed in there, it stops functioning, the valve stops functioning correctly. Starting slide again. Contraindications. These are intuitively obvious. If you have a mechanical prosthetic valve in the tricuspidal pulmonary valve, then you can't use any catheter. You can't risk the catheter getting jammed in the mechanical system or having the catheter break. It could embolize. If you have a right heart mass, you don't have contraindications are intuitively obvious. If you have a mechanical valve in the tricuspid or pulmonary valve, you can understand how it's unwise to insert any tube across the moving valve leaflets. If the catheter gets jammed, you've got problems. If you have a right heart mass, a thrombus or a tumor, you run the risk of dislodging it. And if you have a tricuspid or pulmonary valve endocarditis, in fact, if you have any serious infection in the intracardiac chambers, or in fact, if you have any serious infection, you generally do not do any invasive procedure. Insertion of the catheter is relatively straightforward, but you have to know what you're doing. The catheter is inserted into a major vein via an introducer sheath. It's either the right internal jugular vein, that's the shortest path to the heart, the left subclavian, you'll see a picture of that in a moment. The femoral veins are most commonly used in the cath lab. We are used to these approaches and we can access them very quickly. However, they can be a little more tortuous. Sterile technique, as with any invasive procedure, is essential. And if you're going from the neck, the Trendelenburg position is favored, where the patient's head and neck are raised slightly. And before insertion, of course, you've got to check the Swan-Ganz catheter for cracks or kinks. Here is the catheter in the internal jugular vein. You can see this is a much more complex catheter. It's got more tubes connected to it. This is a case in ITU. In the cath lab, the femoral approach, you all know your femoral anatomy, and the acronym is NAVAL. Nerve, artery, vein, empty space, and lymphatic. It's a useful way of remembering. The cardiologist palpates the artery and knows the vein lies medial to it. And so they can generally find it fairly easily, although it can be difficult with elderly patients with low blood output states. And very rarely they can hit the nerve. And we always know it because the patient always jumps. Not pleasant. To introduce the Swan-Ganz, the catheter is advanced into the IVC approximately 20 centimeters, and only then is the balloon inflated. Once inflated, then it's advanced further into the RV, and the inflated balloon acts as a sail, being propelled by the flow of blood along its natural direction. In the RV, the balloon catheter is turned towards the PA and gently advanced, and it's facilitated by the blood. Generally, no pressure is recorded during entry, and the catheter is advanced into the distal reaches of the pulmonary artery as far as it can go with only gentle force. From there, pressure transducer is attached, and hemodynamics in the right heart can be measured, and blood can be taken for analysis. The thermal dilution technique is one way of measuring cardiac output, and the Swan-Ganz catheter has a built-in thermistor that calculates cardiac output based on changes in thermal dilution. And we'll have a much closer explanation of that methodology at a later stage. It involves injecting a saline bolus, 10 mils, of known temperature and volume, usually 10 mils, at room temperature. It used to be demanded that it be at ice temperature, but improvements in technology have eliminated that need. So long as there's at least a 10-degree difference between normal body temperature, 37 degrees, and standard lab temperature, 23 degrees, then the system is sensitive enough to detect the temperature changes inside the blood. The thermistor at the end of the pulmonary aortic catheter monitors the change in blood temperature and generates a temperature versus time curve. We'll have a look at that in a moment. And this change in temperature, as the warm venous blood in the pulmonary artery is diluted by the injectate, that's cool, is inversely proportional to the derived cardiac output. Again, we'll have a look at the formula and you'll understand why. This is a drawing illustrating how the catheter, as it is advanced through the different chambers right up to the distal reaches of the pulmonary artery. In this instance, pressures are being recorded on the way in. You can see the biphasic right atrial trace. You should all know well by now. You should see the right ventricular trace. It doesn't look very nice, but this is real life. My studies are real life too, but I've been highly selective in what I've shown you. And the catheter then courses. It's been recorded in the right atrium, the right ventricle, and now it's sitting in the pulmonary artery. Once in the pulmonary artery, it's then advanced further and lodged into the wedge position, pulmonary artery wedge. Here is labeled pulmonary capillary wedge. That is a misnomer. It's a carryover from bad nomenclature in the old days. It's not a pulmonary capillary pressure. You're nowhere near the capillaries. Pulmonary capillary pressure is at the level of the capillaries for obvious reasons, and it's not a reflection of the pressure that the Swan-Ganz catheter measures. They're very similar, but they're slightly different physiological measurements. And you can see the wedge. It doesn't have to be perfect. You have to be satisfied that it's a wedge, and there are ways of testing for that. And then you do a reverse of the pressures, first to confirm that they're the same as they were on entry, although, as I've said, most operators tend to go straight into the wedge, record the pressure there. The reason they do that is that they need to twirl and twirl and twirl the catheter, and if it's connected to the pressure sensor, they're restricted in the movement. So they do all the twirling and then they connect, and that shortens the case and makes it easier for everybody. This is that slide I showed you in an earlier lecture. I won't go over it again, but you can see your chambers and you can understand how the Swan-Ganz catheter is recording this pressure from the right atrium, this pressure from the right ventricle, that pressure in the pulmonary artery here, and that wedge pressure. If you advance the catheter right up to the tip, you generate this A and V wave complex. Now, why is that? If you think it through with me, when you occlude that vessel, what are you recording? Remember, the vessels are flowing normally all around that occluded vessel. So pressure distal to that occlusion normalizes. And what that pressure is recording at the end of its continuity, vascular continuity, to the pulmonary veins drain into the left atrium. Well, that occluded vessel, distal pulmonary artery, is actually recording the retrograde pressure from the left atrium. And that left atrial pressure is also the same as the left ventricular EDP. So from the pulmonary artery with a right heart catheter, that's a much safer procedure that relatively less experienced operators can easily do, as opposed to a left heart catheter that's potentially very dangerous. You can obtain a very valuable physiological measurement, the end diastolic pressure. So understand, occluding that vessel simply means you're allowing the retrograde pressure flowing from the left ventricle. Well, it's not actually flowing, but the pressure is being transmitted along that continuous line, that unbroken line, there are no valves in between, to that distal point of the pulmonary artery. That's as much as I'll say right now, or this lecture will become very long. But go through that, and if you read the books, you'll understand it possibly a little bit more clearly. Right and left heart hemodynamics. These are the pressures we measure, and you can see we're recording left heart and right heart pressures. Left atrium is, of course, arterial value, a systemic value, so it's lumped in with aorta, left ventricle, and so it's lumped with the aorta and left ventricle. The right heart values are pulmonary artery, right ventricle, right atrium, and pulmonary artery wedge. You know your aortic pressure is normally 120 on 80, mean of 100. You know the left ventricular systolic value has to be the same in a normal person. So LV is 120, and the normal diastolic value for the EDP is 8. The left atrium, normal values are 7 for the A wave, 10 for the V wave, and 4 for the mean. Pulmonary artery, normal population values are 15 systole, 7 diastole, and 12 mean. Right ventricle, again, same as the pulmonary artery if there are no stenotic pathologies across the pulmonary artery. Pulmonary artery is 15 systole, 7 diastole, and a mean of 12. The right ventricle, 15 and 2. The right atrium is A of 4, V of 4, and mean of 0. And a pulmonary artery wedge is 7, 10, and 4. You must memorize these because in another slide we show another two components showing the normal range of values. And to understand whether something is abnormal or not, you must understand whether it's first within the normal range. And here is another slide showing the pullback in more continuity. The wedge, pulmonary artery, a break where the thermal dilution cardiac output is taken, the pulmonary artery followed by the right ventricle and followed by the right atrium. Notice there are spikes due to movement here and here, and a lot of noise as the catheter is wobbling free from the lodged position. A little spike from catheter whip. Catheter whip is called catheter movement artifact. And at this point is where the thermal dilution connector is introduced and the cardiac output by thermal dilution technique is activated. Normally we do several measurements, 3 to 5, and the values can vary by up to 10% usually. But to be within a reasonable limit of statistical accuracy, you must record the average of at least 3 values that lie within 10% of their mean. And that's not always easy. We'll have a look at some of those, or the potential variety in values down the track. And again, these are all these values. We've gone through the systolic and diastolic values and the means for all our chambers. These are the normal ranges for A and V waves, pulmonary artery wedge, and LA. Go through them and memorize them. You've seen this slide before again. I'm repeating it to illustrate the good appearance that these traces can have, and you can easily identify A and V waves in whichever chamber you identify. Although, in some cases, it's not always that straightforward, and it can be a lot worse. I'm now going to go through a few AVI files, and these will be a little more interesting. This is the Swan-Ganz catheter advancing into the pulmonary artery. You can see the catheter is being twirled and twisted and advanced until it reaches a reasonable distance and it gently stops. So the cardiologist then stops advancing and connects the transducer. That's the Swan-Ganz in the PA. These are stills of that. You can see the balloon in the pulmonary artery in different anatomical sites in different patients. You can see that the pulmonary artery can be in different locations depending on where the catheter falls, either by accident or design. This is just a brief shot of the Swan-Ganz in the pulmonary artery, where you can see it bouncing around. It's not lodged nicely, recording a reflected pressure from a retrograde transmission. It's bouncing around, so it's recording the pressure around it being transmitted forward. Right? So it's clearly identifiable, and you can see it's a good trace of a pulmonary artery, and you would record that. This is a cornad AVI, and you can see there's no balloon at the tip. And you can see the cardiologist is gently advancing it back and forth to make sure it's free. And once he reaches that position, it just bounces naturally. So you know it's not lodged. That confirms that it's a pulmonary artery catheter. The cornad catheter you have to be far more gentle with because it's a stiffer catheter. Pulmonary artery wedge position with a cornad catheter. You can see there's no balloon there or here, although that could be misleading, but take it from me, it's artifact, that little bubbly appearance. And you can see it's wedged reasonably far in, and when these pictures were taken, it wasn't bouncing around. So take it from me, it was a stationary wedge position with a cornad. Sorry. Yes, with a cornad. This is a cornad in the pulmonary artery wedge. You can see it's been advanced and it's sitting there quite nicely in position. A little bit of movement. Again, you have to be a little bit concerned that you don't damage the endothelium of those very small vessels. And finally, we come to the last slide, and this shows very nicely how we obtain that wedge pressure once again. The red line is the Swan-Ganz balloon coursing through the natural anatomical course of the right heart system, locating in the distal reaches of the pulmonary artery as far as it can go to match the diameter of the balloon, where it wedges snugly. Now, with a Swan-Ganz catheter, we're recording not just the pressures in the right heart chambers, but we're measuring the retrograde pressure reflected backwards from the left atrium. We can do this by inflating the balloon at the tip of the catheter and allowing the balloon to occlude a branch of the pulmonary artery. The pressure measured during occlusion is an indirect assessment of the left atrial pressure, and that is the magic of the Swan-Ganz balloon, or even the corner. You can record a very valuable assessment of the left ventricular EDP by accessing the right heart catheter, which is much easier, less traumatic, and less dangerous to do. This is called the pulmonary artery wedge pressure. And as I mentioned, the wedge pressure is also an indirect measure of the left ventricular EDP. In fact, if you measure them simultaneously in the left atrium and the left ventricle, the EDP and the LA pressures are identical. You superimpose them perfectly. But if you think about it, it takes time. It takes a few, not microseconds, but fractions of a second for the pressure to be transmitted across that vascular network from the left atrium to the occluded tip of that vessel. And because of that, you introduce what's called a slight time lag. And so the pulmonary artery wedge pressure is slightly out of phase with a simultaneous recording of a left ventricular trace, which is what we routinely do when we do a left and right heart study for particularly stenotic aortic valve investigations. And we'll see more of that in a later lecture. So with that, I will end this presentation.